Many of the patients had very large spleens, or alternatively had had very large spleens, and they had been removed in order to improve the hypersplenism. That means that they had responses in their blood picture, which was anemia, thrombocytopenia. They felt fatigued. They had bleeding, bruising. All of those things were related to the fact that they had a huge spleen. When it's removed, there's an additional problem of bone involvement, although bone involvement can also happen independently. So what we learned from all of this was that although patients almost always will have an enlarged spleen and an enlarged liver initially, in fact, the enlarged spleen is much more Gaucher specific. And all of the hypersplenism, which is secondary to that enlargement, is also very, very commonly seen. Whereas I would say that thrombocytopenia, the very low platelet counts, is much more specific for Gaucher disease than anemia, because you could see anemia in many other conditions. Some people also develop fractures, and some people will have necrosis of their large joints. But these are things that are very pathognomonic, very symbolic of a symptomatic patient with Gaucher disease. On the other hand, there's a huge population of patients who will never have any of these symptoms. And that's something we shouldn't forget, that now in the new era, where we're identifying patients very early, especially those through newborn screening, for instance, we're seeing patients who might not ever develop any of these symptoms, and yet they do have Gaucher disease. So I think we just have to be aware that there are several populations among the patients with Gaucher disease, and much of it is related to the genotype. So what we talk about is genotype-phenotype correlations. I think, as with every other recessive disorder, which means that one person will receive two mutations, one from each parent, you have to be aware of the fact that that parental pair, or that pair, will be at risk of transmitting a mutation to any one of their children. But it also is true that they themselves are products of previous generations, which might also have had some mutations. So I'm very much in favor of talking to the members of the extended family, certainly first-degree relatives. We can do a blood test, and we could find out immediately whether or not the patient has low enzyme activity, and we can get the genotype all in one little blood evaluation. So it's not asking a lot. Early diagnosis is the most likely scenario wherein we can identify patients who might be at risk for more serious and more symptomatic disease. But beyond that is the opportunity to prevent any kind of devastating secondary feature of the disease, because we've missed the opportunity to treat it early.